picking up with cardiac innervation. So in this diagram, we've got, let me just orient you a little bit. So on the left, on the upper left, you've got the cardiovascular center and the medulla oblongata. So you've got a cross-section there. Below it, you have a cross-section of the spinal cord. On the right, you've got an image of the heart. You've got you're looking at it from the anterior side. And in between the two, you've got some red and some blue lines. Your blue lines are going to be your sensory or your afferent neurons. So they're going to take information from the peripheral organs, and they're going to take that back to the central nervous system. Your red lines are going to be your motor or your efferent neurons. They're going to take those messages out from the central nervous system back to the peripheral tissues to instigate some sort of action. So we have a sympathetic stimulation going on here, and then also a parasympathetic stimulation through the vagus nerve, through cranial nerve 10. Remember, sympathetic is a speed up sort of thing. Parasympathetic is a slow down. So sympathetic is fight or flight. Parasympathetic is going to be rest and digest. So over here, let's start with those blue sensory afferent neurons. You've got baroreceptors in the aortic arch and in the carotid sinus. They're going to actually remember what we said about decreased pressure, decreased firing. We're going to send a message along the glossopharyngeal nerves, which are cranial nerves number 9. And we're going to send a stimulus to the cardiovascular center in the medulla oblongata. That medulla oblongata is then going to send out signals in one of two ways. So we're either going to have a direct send out from the medulla oblongata through cranial nerve 10 along a parasympathetic fiber that then's going to go and join up at the sinoatrial node and the atrioventricular node, or we're going to actually have a pathway that's going to go down from the medulla through the spinal cord. Okay, and then we're going to come out through a sympathetic trunk ganglion. So we're going to leave the spinal cord, we're going to come out through a sympathetic trunk ganglion, and then we're going to enter into a cardiac accelerator nerve. So that would be a sympathetic innervation. Remember, sympathetic is speed up, so we're going to accelerate. And that nerve is going to carry conduction signal back to the SA node, the AV node, and actually to the ventricular myocardium. So we've got sensory information coming in off of cranial nerve 9, the glossopharyngeal, cranial nerve 10, right? The vagus, and then I've got output from cardiovascular center into one of two places, back out that vagus nerve 10 directly to the SA node and the AV node, or we can send that information down the cord out through a sympathetic trunk ganglion where we're going to have a sympathetic influence at the SA-AV nodes and then the ventricular myocardium. Okay, so we can also regulate blood pressure hormonally. So we have the Renin-Angiotensin-Aldosterone System. We talked about that when we were in the blood chapter. We actually went through that slide pretty significantly, as I recall. Remember, we've got some acronyms on this page, or some abbreviations. Remember that ADH near the bottom stands for antidiuretic hormone. That hormone is going to be produced in the hypothalamus. It's going to be released from the posterior pituitary, or the neurohypophysis. It does that in response to dehydration or to decreased blood volume, and the action that it has is to cause vasoconstriction. ANP stands for atrial natriuretic peptide. It's a natural diuretic polypeptide hormone. It actually gets released from the actual myocardial cells in the atria. And we'll talk about that a little more in a second. But let's start up here at the top of this slide. So we have the Renin-Angiotensin-Aldosterone System, or RAS. And what ends up happening here is we have decreased blood pressure or decreased blood flow in the kidney. Our receptors, our primary receptors for RAS are in the kidney. And when we have that decreased pressure or flow in the kidney, what happens is we have a release of a product called renin. Renin ultimately will go through the system and will end up forming something called angiotensin 2. Angiotensin 2 has two main places that it acts. One is directly on the vessels and causes vasoconstriction to increase blood pressure, and then the other place is that the other effect that it has is it initiates an aldosterone release. Remember, aldosterone was produced in the adrenal cortex, specifically in the zona glomerulosa. And what aldosterone is going to do, it was our primary mineralocorticoid, what aldosterone is going to do is it's going to cause sodium reabsorption and thereby water reabsorption at the level of the kidney. Another way that we're going to hormonally regulate blood pressure is through the catecholamines. Specifically, epinephrine and norepinephrine are going to come from the adrenal medulla. What those two hormones are going to do is they're going to increase heart rate and they're going to increase force of contraction. So that heart is going to beat faster and with more force. The other thing that epi and norepi are going to do is they're going to cause a vasoconstriction to those vessels in the skin and the abdominal organs. We're going to move that blood flow away from the skin and the abdominal organs and we're going to push that blood flow, we're going to redirect it to the more vital organs for an emergency sort of situation. Specifically, we're going to see vasodilation in the cardiac and the skeletal muscles. Here's our ADH. So antidiuretic hormone is going to result in a vasoconstriction. By constricting those blood vessels and decreasing that lumen size, we're going to see an increase in blood pressure. And then ANP, remember we said is atrial, A-T-R-I-A-I-L, atrial, like an atrium, but the adjective form, atrial natriuretic peptide. It is going to participate in autoregulation by lowering blood pressure. So it's going to have the exact opposite effect of ADH. So, and even the other two, epi, norepi, and then the RAS system. So it's going to lower blood pressure. How? It causes a direct vasodilation. It opens up, it dilates those blood vessels. The other thing that it does is it allows the kidneys to filter out sodium and water and lose them into the urine and thereby decrease the total blood volume. So when we talk about the hormonal regulations of blood pressure, we have three. Our first three bullet points are going to increase blood pressure. We have the RAS system. That's going to increase blood pressure through systemic vasoconstriction, and then aldosterone release that's going to increase blood volume by retaining sodium and water. We have the catecholamine system from the adrenal medulla in epi and norepi. They're going to increase directly the heart rate and the force of contraction, thereby increasing blood pressure. They're also going to aid in the vasoconstriction at the skin and abdominal organs, and vasodilation to the cardiac and skeletal muscles. ADH, antidiuretic hormone, is going to cause a vasoconstriction. So all three of those, RAS, epi, norepi, and then ADH, are all going to cause an increased blood pressure. Your fourth one, ANP, atrial natriuretic peptide, is going to cause a decrease in blood pressure. It's going to do it through vasodilation, opening up those blood vessels, and then allowing the kidneys to release salt and water into the urine. And next up on our list, we're going to talk about circulation and how we evaluate circulation, specifically taking blood pressure and what that means.